All right, so very good evening, everyone. I welcome you all to this particular YouTube session on the image-based questions on cardiology. Right, so let me discuss this image-based questions on cardiology. So in my previous session, this is like part 2, if I'm not wrong, part 2 of the image-based questions on cardiology. So already in my previous sessions, I have discussed some questions on the cardiology, and this is my second session. And on this platform of Arise Medical Academy, I have done almost 8 to 9 sessions of, right? I have done almost 8 to 9 sessions of the image-based questions on various chapters of general medicine. So those students who did not watch the previous sessions of image-based questions on various chapters, please watch them. That will be image-based questions are very much important questions in your upcoming FMGE exam, right? Because almost you get 80 to 90 images in the FMGE exam, out of which, if I'm not wrong, 10 to 15 images will be related to your general medicine. So please utilize this particular opportunity of the free sessions on image-based questions, right? Yes, Jinesh, Jain, huh? Okay. Right, so good evening and hello everyone. Okay, let us start with the session first. Yeah. Now, in the image-based questions related to cardiology, some of the questions will be on ECGs. Okay, you see the first question. Abnormality, right? Abnormality shown in the photograph is not found in, right? Abnormality shown in the photograph is not found in MI, coronary artery spasm, constrictive pericarditis, ventricular aneurysm. I have discussed this. If you have gone through my sessions on the cardiology on the platform of Prosium, there I have discussed the same. Right. So who's that answer first? Rajkumar. Very good, Rajkumar. The answer is constrictive pericarditis. Rajkumar, please tell me, what are the ECG changes in constrictive pericarditis? What are the ECG changes in constrictive pericarditis? So if you take the ECG changes in constrictive pericarditis, you will have, anyone in fact? Right. So you will have what is called the presence of low voltage complexes. Right, the presence of low voltage complexes. Okay, that is what you will have in case of constrictive pericarditis. But what is that you are having the ECG change in the image which is shown to you? In the image which is shown to you, the ECG change, what you are seeing is ST segment elevation. Right, whatever the ECG change, what you are seeing here is the ST segment elevation. And this ST segment elevation you will not have in constrictive pericarditis. But ST segment elevation can be seen in acute pericarditis, but not in case of constrictive pericarditis. So, and always remember one important point, ST segment elevation in the ECG It doesn't mean only MI. In MI, you will have ST segment elevation. Coronary artery vasospasm, you will have ST segment elevation. What is that condition where you will have coronary artery vasospasm? Any one of you? What is that condition where you will have transient coronary artery vasospasm? So, very good. So, the transient coronary artery vasospasm is seen in what is called vasospastic angina. Right, you will have that in case of vasospastic angina. So in vasospastic angina, which is also called Prince-Metal angina, right, which is also called Prince-Metal angina, you will have that particular the ST segment elevation. And even in the ventricular aneurysm, right, even in the ventricular aneurysm, you will have that particular the ST segment elevation. You will have that ST segment elevation. Okay, right. Now, I will tell you the ST segment elevation in the ECG are seen in multiple clinical scenarios, not just only these four what I have discussed. I have discussed MI, coronary artery vasospasm, ventricular aneurysm, acute pericarditis. These are the etiologies what I have said you about ST segment elevation. But apart from this, there are many other conditions. Let me tell you. Now this is a mnemonic, right? So this is a mnemonic for the conditions causing ST segment elevation. What is that mnemonic? That particular mnemonic is elevation AB. That mnemonic is elevation AB. Let me tell you. So what does this elevation AB stands for? The word E stands for electrolyte abnormalities, that is hyperkalemia. The word L is your left bundle branch block. The word E is your early repolarization variant. And the word V is your ventricular aneurysm. And the word T is your pericardiocentesis. That is trauma actually. And what particular trauma? That is pericardiocentesis. The word I is your ischemic injury, that is MI. The word O is your Osborn wave. Osborn wave, you will see that in patients with a hypothermia. You will see that in patients with a hypothermia. And non-occlusive vasospasm. That is nothing but Prince-Metal angina. That is nothing but Prince-Metal angina. Okay. And A stands for acute pericarditis. B stands for Brugada syndrome. These are all the conditions where you will have ST segment elevation. MI already I have said, Shashibhushan. This is your MI, ST segment elevation MI. So these are like multiple conditions where you will have ST segment elevation. Okay, but in the options which is given to you, like you take constrictive pericarditis, you will not have ST segment elevation. Acute pericarditis, you will have ST segment elevation. Okay, right. So this is a very important image-based question on the ECG showing ST segment elevation. Now, let me move on to the next image. Yes, this is how the ECG of low voltage complexes appear. This is what is the ECG of low voltage complexes. And where do you have this? You will have this in case of constrictive pericarditis. You will have this in case of massive pericardial effusion. Right, massive pericardial effusion. Okay, and what is the criteria for low voltage complexes? The criteria for low voltage complexes is the amplitude of the QRS complex in limb leads, it should be less than 5 mm. Whereas in the chest leads, that should be less than 10 mm. Okay, so in the limb leads less than 5 mm, in the chest leads less than 10 mm. Less than 5 mm in the limb leads, less than 10 mm in the chest leads. Okay, right. That is what is the criteria of low voltage complexes. Next. Yes, this is another interesting image. Very, very interesting image. So whatever the image which is shown to you is the pulse waveform. Right, it is the pulse waveform. Okay, so pulse shown in photograph is associated with constrictive pericarditis, restrictive pericarditis or restrictive cardiomyopathy, cardiac tamponade, lung cancer. Right, very good, Prithvi Basurai. The answer is the cardiac tamponade. The answer is cardiac tamponade. So what is shown to you here? This is nothing but Pulsus paradoxus. Right, this is nothing but the Pulsus paradoxus. That is what is shown to you here. Now, what is the definition of Pulsus paradoxus? Okay, but before that, please tell me what are the other conditions where you will have Pulsus paradoxus? Any one of you? What are the other conditions where you will have Pulsus paradoxus? Definition of Pulsus paradoxus is fall in the blood pressure more than 10 millimeters of mercury during inspiration. Right, fall in the blood pressure more than 10 millimeters of mercury during inspiration. That is what is called Pulsus paradoxus. That is what is called Pulsus paradoxus. And you take the other conditions. The other conditions where you will have the Pulsus paradoxus is you will have this in patients with the severe COPD. You will have this in patients with the status asthmaticus. Right, and you will have this in patients with the morbid obesity, and you will have this in patients with the cardiac tamponade. Okay, now let me explain you that even in the image also. You see, whatever is shown to you in this particular waveform is nothing but your blood pressure, right? See, this is your waveform. Okay, this is nothing but your blood pressure. Okay, and how much is that particular blood pressure fall in a normal individual? Less than 10 millimeters of mercury. But here there is also some additional fall. There is also some additional fall. And how much is that additional fall? That is more than 10 millimeters of mercury. That is what you will see in what is called Pulsus paradoxus. Right, so Pulsus paradoxus is like the fall in the blood pressure more than 10 millimeters of mercury during inspiration. That is what is called Pulsus paradoxus. Okay, next. Now, followed by that, we will move on to the next image based question. Yeah, so you see this. These are all the causes for Pulsus paradoxus. Cardiac tamponade, I have said you. Okay, and severe COPD, emphysema, bronchial asthma, that is status asthmaticus, hypovolemic shock, pulmonary embolism, morbid obesity, pregnancy. Right, very, very rarely, sometimes you can see that in case of chronic constrictive pericarditis. Very, very rarely, sometimes you will see that in case of chronic constrictive pericarditis. And you have one more terminology that is called reverse Pulsus paradoxus. Reverse Pulsus paradoxus is seen in patients with a hypertrophic obstructive cardiomyopathy. It is seen in patients with a hypertrophic obstructive cardiomyopathy. So that was the image related to your pulsus paradoxus. Okay, now you see this. Appearance of the waveform shown in photograph is due to, right? And what is the waveform shown to you? The waveform which is shown to you is the CVP, which is nothing but the jugular venous pressure, which is nothing but your jugular venous pressure. Yeah, answer. Options are atrial fibrillation, constrictive pericarditis, the cardiac tamponade, junctional tachycardia. Okay, now let me trace out the waveforms. The answer in this question is no, I am not getting the correct answer from. Yes, so the answer here is, it's not D actually, I'm sorry. The answer here is, why are you telling constrictive pericarditis? The answer is cardiac tamponade, right? The answer is cardiac tamponade. Okay, you see, this is your A, this is your C, this is your X, this is your V, and this, you, what all you should have? A, C, X, V, and Y. So now tell me, do you have Y wave in this JVP? Do you have Y wave in the JVP? Right, very good, Soumya. Excellent, Soumya. So your Y wave is absent. You see, this should be your Y wave. Right, this should be your Y wave. Okay, so the Y wave, it is small or it is absent. Y wave, it is absent. So when the Y wave is absent, where do you have that? You will have that in cardiac tamponade. In cardiac tamponade, there is diastolic collapse of the ventricles. Right, there is diastolic collapse of the ventricles. There is no atrial emptying. So because of this diastolic collapse of the ventricles, atrial emptying does not occur. Right, atrial emptying does not occur. So when atrial emptying is not there, there will be no Y wave. Right, there will be no Y wave. Okay, so that is about the, and you take the other conditions. In constrictive pericarditis, what will be the JVP findings? Can anyone tell me what are the JVP finding in constrictive pericarditis? In constrictive pericarditis, please remember that you will have deep Y and X descent. Right? And in atrial fibrillation, the A wave will not be prominent. Right? Will not be prominent. Okay? So that will be the JVP findings in various scenarios, various clinical conditions. But whatever the JVP given to you is like your Y wave being absent. And what is that condition? That is your cardiac tamponade. That is your cardiac tamponade. Okay. Now you see the other image. Yeah. Vascular condition shown in the photograph occurs due to estrogen, steroids, androgens, progesterone. So what is that you are observing there? What is that image suggestive of? Right, very good, Mohammed Umar. But please tell me the diagnosis of this image. Any one of you? What is the diagnosis of this image? See, this is nothing but a form of excellent, Mohammed Umar. This is your, I cannot tell you exactly spider nevi, right? But I can call it as a doubtful spider nevi. And among the drugs given, which can give rise to this picture, or among the options given to you, which can give rise to this picture? That is whenever there is hyperestrogenemia. So where will you have this hyperestrogenemia? You can have that in patients with a cirrhosis of liver. Right? You can have that in patients with a cirrhosis of liver. Okay. So that is about the story of the spider angiomata. That is about the story of spider angiomata seen in cirrhosis of liver. And why? That is because of hyperestrogenemia. And because of increase in estrogen, you have multiple manifestations in cirrhosis of liver. Right? So there can be gynecomastia in males, right? And there can be testicular atrophy in males because of hyperestrogenemia. Okay. Right? Why there will be hyperestrogenemia in cirrhosis of liver? The estrogen has to be metabolized in the liver. But the point is, the estrogen is not getting metabolized because the liver is damaged. So that is the reason why there is hyperestrogenemia. Okay, right. So endocrine disorder associated with this ECG abnormality. So what is that ECG abnormality you're making out here? That is your U wave. So where will you have your U wave? You will have that in patients with the hypokalemia. Right? You will have that in patients with the hypokalemia. Right? So in the options given to you, which condition will cause hypokalemia? That is your Conn syndrome. That is your Conn syndrome. So Conn syndrome, it will cause, there will be increased sodium and water retention. There will be hypokalemia, and there will be also decrease in the H plus ions. Right? There will be also decrease in the H plus ions. That is what you will see in the Conn syndrome. That is what you will see in the Conn syndrome. Okay. So there will be metabolic alkalosis. Right? And there will be hypokalemia. There will be hypokalemia. Right? And there will be increased sodium and water retention. So in hypokalemia, what will be the other ECG changes? In hypokalemia, the other ECG changes are, there will be decrease in the amplitude of the T wave, or there can be inverted T wave, right? Or there can be inverted T wave. Okay, so that is about the ECG changes in hypokalemia, right? And in hypokalemia, even if you take this ST segment will be depressed. ST segment will be depressed, and you take this P wave, they will have what is called pseudo P pulmonale. They'll have what is called pseudo P pulmonale. Okay, right? So these are the ECG changes in hypokalemia. But definitely, yes, the appearance of the U wave is the earliest change. Right? The earliest changes, the appearance of the U wave, prominent U wave. Next, we will move on to the next image-based question. Yeah, you can see the ECG of the hypokalemia. Yes, you see, this is your U wave, right? And this is your T wave being inverted. And they will also have prolonged QT interval, or we call it as QU interval, because your T wave or your U wave, it is getting merged with the T wave. That is why we call it as prolonged QU interval or prolonged QT interval. Right? Next. Yeah. Following are the features of raised intracranial pressures. Right? Or which among the following ECG features are not seen in raised intracranial pressure? Right? Raised intracranial pressure is associated with ECG changes, with following ECG changes, except, that means which among the following is not the feature of raised intracranial pressure? That is what is the question. Widespread giant T wave inversions, QT shortening, bradycardia, ST segment elevation or depression. Which of the following is not the ECG change in raised intracranial pressure? Anyone? Right. So in case of raised intracranial pressure, right, in case of raised intracranial pressure, you take the T wave. You take the T wave. So T wave is a giant T wave and it is inverted. Right? The T wave, it's a giant T wave and it is inverted. And if you take the ST segment, right, ST segment, it can be depressed. ST segment, it can be depressed. It can happen. But remember about the QT. What will happen to your QT? The QT will not be shortened. The QT will be prolonged. Right? The QT will be prolonged, but not QT shortening in case of raised intracranial pressure. And the other ECG change in raised intracranial pressure will be bradycardia. Bradycardia. Okay. So you go back to the question now. There will be giant T wave inversion, widespread in all the leads. QT will not be shortened. Right? The QT will not be shortened. There will be QT prolongation. Right? There will be QT prolongation. And Bradycardia will be there. That is nothing but your Cushing's reflex. And ST segment, either it is elevated or depressed. That is also correct. But QT shortening will not be there. QT prolongation will be there. That is what you will see in the raised intracranial pressure. That is what you will see in raised intracranial pressure. Okay. So you have that widespread T wave inversion. You see, in all the leads, the T wave are inverted. And that too, it is completely widespread. Right? Widespread T wave inversion. Okay. And that too, giant T waves, which are being inverted. Next. Now we will move on to the next image-based question. Yeah. This will be a little difficult for you. I'll move on to next. Okay, but anyways, it will be like showing yes. You see this question, last question. Okay, last question. 84-year-old male patient presents complaining of fatigue, nausea, several episodes of diarrhea and dizziness. There is also past history of atrial fibrillation, diabetes mellitus, and hypertension. And the medications used by the patient are aspirin, ACE inhibitor, statin, sulfonylurea, and digoxin. Presently, he is like conscious, vague, but oriented. Blood pressure is 112 systolic blood pressure. ECG has been done in the individual. What is the ECG? First degree heart block, Mobitz type 1 AV block, Mobitz type 2 AV block, complete heart block. You see all the complexes properly, and then you come to the diagnosis. So what is that you are able to make out here? You see, this is your PQRST complex. But here you have a P wave, but there is no QRS complex. Same thing in the next also. This is your PQRST complex. You have a P wave, but there is no QRS complex. You have a P wave and there is no QRS complex. What is this suggestive of? Right? What is this suggestive of? Here, there is no association between the atrial complexes and ventricular complexes. There is no association at all between the atrial complexes and ventricular complexes. Right? And here also you see there is PQRST complex and you have a P wave and no QRS complex. Here also, and here there is no P wave at all, but you have the QRS complex. And here you have P wave, but no QRS complex in between. So there is complete AV dissociation. There is complete AV dissociation, and that is suggestive of complete heart block. Right? That is suggestive of complete heart block. How do you diagnose others? Let me explain in a very briefly, in a nutshell manner. In first degree AV block, right? In first degree AV block, there will be prolongation of the PR interval. That's all. There will be prolongation of PR interval in first degree AV block. And you take second degree AV block. Second degree AV block, it is of two types. Mobitz type 1, Mobitz type 2. So you take Mobitz type 1. Mobitz type 1, there will be progressive prolongation of PR interval. Right, progressive prolongation of the PR interval, and there will be non-conducted P wave. Right, there will be non-conducted P wave. Okay, and in Mobitz type 2 AV block, the PR interval is constant, but there is intermittent non-conducted P wave. That is Mobitz type 2 AV block. And Mobitz type 1 AV block, this is also called Wenckebach's phenomenon. Right, this is also called Wenckebach's phenomenon. Okay, right, CHS. And in third degree AV block is nothing but your complete heart block. That is what we have seen the ECG. That is what is your complete heart block. So these are the ECG changes you will have in the AV block. In first degree AV block, there is just only prolongation of the PR interval. That's all. Second degree AV block, again we have two types, Mobitz type 1 and type 2. Right? Mobitz type 1, there is progressive prolongation of the PR interval, and subsequently there will be non-conducted P wave. And Mobitz type 2, the PR interval, it will remain constant, but intermittent non-conducted P wave. Intermittent non-conducted P wave. And in third degree AV block, that is your complete heart block. There is no association between atria and ventricles. So that is what you are seeing in this ECG. Whatever the ECG which is given to you, it is the ECG of complete heart block. There is no association between the atrial and as well as the ventricular complexes. Right? So these are some of the images in the today's session. And subsequently, I'll be back in front of you live with some more images related to your cardiology. Right? So until then, thank you very much. Good night and see you in the upcoming sessions.